During Migraine Awareness Month, we're getting to speak to so many interesting people, including people not in Australia. With us today, we have Dr. Camille. She's a former ER doctor who now works exclusively in migraine and is a great specialist for us to talk to. And we're going to be talking about hormones and migraine, which I know many of you want to know all the things about. Thanks for joining us, Dr. Camille.
Yes, thank you for having me.
Tell us a little bit about yourself and what you do there.
Well, I am still actually a practicing emergency medicine doctor. You know, some of my personal experience has gotten me more and more into, I'm actually taking a specialty board in headache medicine. But, you know, I've been a lifelong chronic migraine sufferer since I was about 20 years old, and pretty refractory symptoms. I've tried, you know, every prophylactic in the book, every, you know, supplement. And it kind of, then I went through my own hormone journey where, you know, after the birth of my first child, I just didn't feel right. I had chronic migraine, no medicines worked. This went on for about 5 years to where I almost became permanently disabled. And I kind of had to become my own physician, my own advocate, and find my own way back. And part of it was through hormone therapy. So, you know, at that time, it turned out my testosterone was undetectable and had to treat that. And then there was another time where, you know, as I entered into the perimenopause time, my estrogen was sky high and fluctuating. And so I really just began to realize, you know, how important hormones are, not just for general health and well-being, but they're really important in migraine medicine. And I think really mostly overlooked by traditional westernized medicine. So I think when you have migraine, especially, you know, pretty refractory or chronic migraine, you have to use lots of different types of treatments, and that includes migraine. So, I mean, it includes hormones. So that's kind of led me on my journey to becoming specialized in hormone medicine and open up a clinic where I can offer comprehensive care to migraine people, including not only pharmacologic treatments, but hormones, as well as Botox, which is great for migraine, and then, you know, acute care kind of stuff like we would do in an ER.
Tell us, what is the connection at the most basic level between hormones and migraine?
The biggest thing is estrogen. And so that's really what leads to many more women being affected by migraine than men. Not that men don't have estrogen, because they do, but they don't have the fluctuating hormones and fluctuating estrogen that women do. And that's really the crux of how it affects our migraines and why migraines really kind of wax and wane throughout life, depending on what kind of stage we're in and what our hormones are doing. And so, you know, when children are starting out, actually boys and girls have the same amount of migraine. But when girls hit puberty is when the migraine in women really takes off and goes to, you know, more than 5 times men's. And that's because our hormones are ebbing and flowing. And so that's why, you know, we start noticing it in puberty. In fact, some people will kind of experience their first migraine around puberty. And then, as we'll talk a little bit later, you know, as you then go through things like pregnancy or perimenopause or menopause, all these things are affecting sort of the ups and downs of our hormones, and that's really what causes migraines.
And that's why we have this thing called menstrual migraines or hormonal migraine, yeah?
Right. So menstrual migraine, so migraine in and of itself is, you know, having recurrent episodes of severe pain, oftentimes on one side of the head, oftentimes associated with nausea, vomiting, light sensitivity, all those things. And those can happen either, people can have episodic migraine or chronic migraine. So episodic meaning, you know, once in a while, no rhyme or reason. Chronic is when you're having more than 15 migraines per month, but there's kind of a subset, and it is a little different than traditional migraine, is menstrual migraine. And that's defined by being specifically tied around your period. So specifically happening 1 or 2 days before the onset of your menstrual flow and occurring for a few days afterwards. Now, some women can have both. If you're lucky enough, you can have, you know, episodic or chronic migraine and then additionally have menstrual migraine. And again, the menstrual migraine is specifically tied to the period. That's kind of a little bit different, and it's related to the really quick drop in estrogen. So right before the onset of menstruation, your estrogen really drops, and that's what triggers the migraine.
So it's the fluctuations in the estrogen that triggers things
Right.
off.
It's the quick drop that causes it. And so there's a couple things that you can do. Now, if that's the only time you have migraine and you don't need to worry about, treating chronic migraine, then there's a couple strategies that you can use for that. One would be, kind of probably the easiest would be to try a trial of medicines just around that time when your period's going to start. This is, can be a little bit tricky because one, you have to have really regular cycle and know when it's coming. And some people, don't have it that regular, don't want to be counting all the time. When's it going to come? I got to start these meds. But if it is really regular and really only affecting you during that time, the first kind of quick and easy way to try to treat it would be taking naproxen or ibuprofen about 5 days before your period starts. Right. And most of the studies are done on naproxen. I don't know if that's what you guys call it in Australia.
That's the generic name. Yeah, it's fine.
Yeah. But taking that twice a day for 5 days before the onset of menses and continuing that for about 5 days after does show some good improvement in women. Another strategy that's really not used that much, there's a class of migraine medicines called triptans, you're probably familiar with. And mostly, especially in the US, we use those as abortive, like you take that. But there is a strategy where you can do one of the longer acting triptan medications like frovitriptan, where you could take it twice a day for about 2 days before the onset of your menses and continue that for about 2 days after. And that actually works very well to control people's menstrual migraines as well. The kind of one of the difficulties with that is, most people have a hard time getting enough of the triptans. Triptans are usually kind of regulated and you can only get, 6 or 9 a month, especially in the US. And so that might kind of use up some of yours. But, if, again, that's the only time you're really having them, that's a strategy that I tried. And then the other strategy that could be considered would be, since it is related to the estrogen really dropping at that point, would to be adding in just an estrogen supplementation around that time. Either a topical estradiol or an estrogen patch that you would just start about 2 days before the onset of menses, taking it off about 2 days after.
What about the use of contraception to kind of even out?
Right. So those are ones for, that if people want to count, but a lot of people don't want to kind of be forced to always be figuring it out. And so using a combined low estrogen birth control can work really well. And the key being, again, is that you would want to skip your placebo week. So if you're taking it, for 3 weeks and then you stop and do the placebo pills for a week, you're essentially still having that big drop in estrogen withdrawal. So you can try a low dose combination estrogen pill and then just skip the placebo week and keep doing it continuously. And again, since we're trying to treat those really the fluctuations in the hormones, this gives just a continuous dose, and that will help a lot of women. The one caveat being there is a type of migraine called migraine with aura, which is only in about 5% of people with migraine, and they have some extra sensory issues like flickering lights in their eyes, vision loss, kind of pins and needles sensations. There's a lot of evidence that says that those people specifically are at increased risk of an ischemic type stroke and probably should stay away from estrogen altogether, estrogen supplementation. But for everyone else, considering the use of a combined pill would work. And, just remembering that everyone's different. Some people can't tolerate a hormone estrogen pill at all. That will actually cause worse migraines. But, for those that they tolerate that, and if you're in that stage of life where you're also looking for, some contraception, then that's a nice option.
Yeah, not so much if you're trying to get pregnant, obviously. Right. Contraception is going to mess with that a little bit. Right. So talk to us a bit about what happens in pregnancy, because some people say in pregnancy they're great, they have no migraine attacks at all, and other people it gets much worse.
Right.
So what's going on there?
Well, again, we're all different. And so some people, but, when you first become pregnant, many people will have actually worse migraine in the first trimester. And that's, again, because levels of your hormones are rising. And again, it's that fluctuation or changing hormone levels that's triggering it. So the first trimester is really tricky for a lot of migraine patients. And, most doctors will tell you, don't take anything at all. And so it leaves them really with a lot of pain and stuff. But generally, as you get into your second trimester, your hormones become very high and stay that way. So from your second trimester through your third trimester, your hormones are the highest they'll ever be in your life and very steady. And so that's why many women will have significant improvement in their migraines during that time, because of the steady state of the hormones. If you are in that category, especially in your first trimester where you're really struggling, you should probably try at least some supplements. And there are some supplements that are safe in pregnancy. Some of the ones that are kind of most looked at for migraine prevention, like magnesium, B2, riboflavin, even like feverfew and butterbur. Some of those things may help. Some women are already on some prophylactic medications. And again, if you absolutely don't need it, you should come off of it. But sometimes even just continuing it through the first trimester, like if you're on beta blockers like propranolol or even some of the antidepressants, the benefit may outweigh the risk. But once you get into the second and third trimester, you're pretty good, most people, because of that high hormone level. But then coming out of pregnancy again can really trigger some problems for migraine sufferers, because you go from the highest your hormone levels ever are to dropping to the lowest they ever are. And that usually actually doesn't happen where you're having a lot of symptoms until if you're not breastfeeding or once your period returns. But again, that creates a lot of havoc for migraine sufferers.
Just a little bit, yeah. Okay, so let's talk about the other point in time when our hormones create havoc: perimenopause and menopause.
Yeah.
The same thing, it's dropping, triggers the
right. It's dropping. Well, in the perimenopause state, there's two things. One is your hormones are starting to really drop, and so some women may benefit just from adding some progesterone and or estrogen as well, and even testosterone. I don't think testosterone's considered enough in women, but women need testosterone too, and your testosterone will drop during this time. And testosterone, even independently, if it's low, can be linked to migraine. So it's really all the hormones that need to be looked at and addressed. But the other thing that happens in perimenopause, for some women, their hormones are just dropping, and for many women, their hormones start kind of going really erratic. And if you check your hormones 1 month and then check them the next month, you might see completely different results. And so probably this time in a woman's life is the hardest, not only to control symptoms, but you have the most symptoms. And so the estrogen is well known to go very, very high and cause an estrogen dominance, and then go very, very low and kind of go back in a month. So again, this is going to be a tricky time. Usually adding some supplementation in estrogen, progesterone, or still continuing on that combined hormonal contraceptive pill like we talked about earlier. Anything that will kind of quiet the ovaries or keep you in that steady state of hormones. One thing we didn't talk about too is, for people who, can't tolerate estrogen or shouldn't be on estrogen, even just going to a straight progesterone style hormone, especially during the time that you need contraception, would help as well. So, some women really do well on Depo or just straight progesterone, because it usually forces your ovaries to become very, very quiet. So again, you're not having any of those hormonal fluctuations. And usually if you're not ovulating, you're not going to have those hormonal changes. And so progesterone alone will kind of quiet that. And some women will have a lot of improvement just by doing that. Now, once you get through the perimenopause stage and you get to menopause, that's when most women will actually have a lot of relief, because now your hormones have dropped to a very low level and they stay low. And that's when you have a lot of relief from symptoms typically. And during this time of the hormonal fluctuation, you may need to some other strategies, which, usually perimenopause is around your 40s. So you may, want to have some Botox for cosmetic issues. And luckily, that's one thing that really, really helps a lot of people with migraines is getting Botox. And there are a lot of prophylactic medications we use for migraine that are also, antihypertensive medications. And so, in your 40s, you might start having some blood pressure issues. So you might consider, a pill that could also give migraine improvement, like a beta blocker, like propranolol, even some of the ACE inhibitors like Lispril has shown some improvement in migraine. So there's some things that you might want to target two things at once, like when we're talking that you're looking for contraceptive, using a birth control pill, you're maybe using something that controls your blood pressure and gives some Botox or something like that.
Just back to that ACE inhibitor. What was the ACE inhibitor you mentioned?
Lisinopril.
Okay, just for the flip side, so the guys don't feel left out here. So we notice in some of the statistics and stuff that the diagnosis of migraine increases for men after 70. I presume that's the same thing. Their hormones are changing as they get older.
Yeah, that's right. And men are a little bit different. A lot of that for them is their testosterone dropping more than, estrogen changing. And like we mentioned earlier, a low testosterone is linked with migraine. And so, adding in some testosterone is very important for men's overall health, cardiovascular health, bone health, but also would help their migraines. And then, of course, for them using, typical kind of migraine control methods as well.
Thank you so much for making the time, Dr. Camille.
Thank you for having me.
Happy Migraine Awareness Month.